All right, we're going to go ahead and get started. But before we do that, I just want to talk about CE real quick. I sent out an email talking about CE. If you haven't got it done yet, just start getting CE hours in. That can look like attending these events. It could look like books, TV shows, or anything like that. By the end of the year, we're supposed to have 12 hours. And I've been trying to keep up with that with y'all. If you send me an email, I try my best to log that in and everything. This event is 1.5 hours for CE, so that's to your 12. Let's see. Any announcements? Kathy, do you have anything? No? Yes. Y'all are troopers. Of course. But before we get started, this is Halle Ross-Young. She is a psychologist at UT Tyler. So I'll give it to you.
Yeah. I am excited to be here today to talk about trauma with y'all. I will say this is a pretty heavy topic, so just know kind of as we're progressing through it, if you need to take a break, feel free to step out. It is some tough stuff we're talking about. But I'm excited. I hope it'll be some new content because we're going to talk about the biopsychosocial impact of trauma, as well as some treatment recommendations given the biopsychosocial impacts. So let me see if I can advance my slides. It is not. Sorry. There it goes. There it goes. You just have to push the button the exact right way. And so, yes, I am a psychologist with UT Tyler School of Medicine, primarily on our inpatient psychiatric units, but I also do some outpatient work and a lot of education. Just to disclose, I have no financial or other conflicts of interest for today. And all the material in this presentation, I'm presenting on behalf of myself and not on behalf of UT. I will also say I'm not monitoring the chat. But Lee is able to do that for me. So if you have questions from Zoom or anyone in the audience at any point, feel free to raise your hand, shout them out, drop them in the chat. And I want this to be interactive as we go. So you don't have to hold them till the end. My learning objectives for today is I hope that folks who attend will be able to identify the specific categories and examples of some of those adverse childhood experiences or ACEs that some of the folks that you work with may experience. Discuss some of the DSM diagnostic criteria and other trauma-related disorders you may see in children and adolescents, even non-psychiatric disorders. Identify the diffuse effects of childhood trauma exposure throughout the lifespan, and then discuss some best practices for identifying and screening for trauma exposure, as well as ways to incorporate trauma-informed care and practices into all of our work that we do. And considering referrals to appropriate evidence-based trauma treatment. So first, the biopsychosocial model. Have folks heard of this before? Kind of familiar with the language? No? Okay. So it was first developed by Engel in 1977 as an alternative to what was the predominant theory at the time in the practice of medicine, which is the biomedical model, which was entirely focused on like your hormones, your blood work, right? Your genes, like what is physically going on. And what the biopsychosocial model did was intentionally incorporate these psychological and social factors into our understanding of health and disease for folks. Since the 70s, it's really become the dominant model of medicine, in part because it's really characterized by the fact it's interdisciplinary in nature. Right? In order for us to be able to recognize and address all of these components, we need more usually than just a physician, a singular primary care physician, or example, to address all of these things. The core features of the biopsychosocial model are really that our biology and understanding of health and illness can't just be drilled down to simple physics and chemistry, right? There are other things that impact our health, our well-being, our functioning, which I'm sure many of us in this room would probably agree with as a principle. It also recognizes that this concept of mind-body dualism isn't supported by science. So previously, there was really this idea of like, well, if something is going wrong physically, it doesn't have an impact on someone's mental health And the opposite was kind of assumed to be true, right? If something was going on for someone psychologically, it's not necessarily impacting their physical health. What the biopsychosocial model recognizes is those two things are inextricably linked for folks, and they do influence each other. And so the biopsychosocial model incorporates this understanding of like expectancies and beliefs, right? If people expect a treatment to work, we do know that there's a positive effect in terms of things being more effective. It takes into account some cognitive theories and learning theories. So like how people experience going to their doctor, right? Like if folks are hesitant to go, they've had previous bad experiences with the medical system, for example, how that impacts our health. And it also emphasizes some of these non-medical drivers of health. So things like someone's social status or their financial strata or their race or ethnicity or their linguistic ability, right? How that impacts someone's health, someone's access to the healthcare system, and the quality of healthcare that they receive. And it also emphasizes this role of chronic stress. And so this little image is nice because it kind of breaks down some of the different components that we see in each of the biological, the psychological, and the social components of this model. So you can see if we're looking at biological, that is things like, genetic issues, illness, disability. If we're looking at psychological, we're looking at things like someone's behaviors, their personality features, traits like impulsivity, self-esteem, things of that nature. And if we're looking at social components, that's where things like someone's economic status or religious affiliation or their social relationships with others or with culture kind of come into play. And then we have these kind of overlaps between areas like trauma exposure, which is what we'll be focusing on today, things like gender, which is like the biological and social combination here, attitude, and all of these combine to kind of create our understanding of health or illness. Does that make sense? Awesome. So what are adverse childhood experiences? Have folks heard of ACEs before? Awesome. So we won't beat this dead horse too much, but essentially an ACE is defined as a potentially traumatic event that occurs prior to the age of 18. So it's occurring in the developmental period, and it can have negative and lasting effects on someone's health and well-being. This was first described really in a study in 1998 by Felitti and colleagues. They actually were physicians who were setting out to research some of the most common causes of morbidity and mortality in the United States. So things like diabetes, cancer, right, nicotine use. And what they ended up finding when they were screening for these ACEs was these were huge risk factors for these leading causes of morbidity and mortality in United States adults. And so that's what really sparked the interest and then the field of studying ACEs. So it was kind of one of those serendipitous things where they didn't think that that's what was going to happen in this study. They ended up kind of getting this data and going, oh, this is a much bigger deal than we thought it would be. And so the broad categories that they kind of identified based on their study is abuse, which they broke down into physical, sexual, and psychological or verbal abuse. Emotional and physical neglect was another broad category. And then they kind of had this broad category of household dysfunction, which they broke down into smaller criteria of things like exposure to parental substance use, exposure to parental mental illness, or parental separation for some reason or another in the home. That could be divorce, abandonment, suicide, a parent going to jail or to prison, right? Could be parental separation, witnessing domestic violence, which they specifically labeled as violence toward a mother or stepmother in the household, and criminal behavior occurring within the household as sort of these categories of dysfunction. Since that time, a lot of studies have looked into ACEs, what are ACEs, even globally. And so these are some additional ACEs that have more recently been identified from different samples that have been kind of gathered in the research across the globe. And as you can see here, it's a it's a pretty broad list of things that folks might experience before the age of 18. So, including things like a parentification role for a child, experiencing poverty or displacement, living in an unsafe neighborhood, inequality of resources, isolation. This was really one that came about as a result of COVID and the pandemic, right? Is kind of understanding the impact of increased isolation on children and adolescents, long-term parental unemployment, low school attendance, things like that. So of these, what do you think of the kind of list of ACEs that we have? And I can go back to them. And do any of them kind of surprise you?
What was your question?
Yeah, do any of either these ACEs or kind of these here in this list, is it surprising to you that any of these are considered adverse childhood experiences?
Expand on the socio-political events.
Mm-hmm. Things like climate change, like wars or conflicts, really divisive commentary, are kind of some socio-political events that can be stressful to children and adolescents. Great question.
What about military deployments?
Mm-hmm. I think that would definitely fall under parental separations, right? Certainly could be an adverse childhood experience. So that may be one that needs to be listed. Because my next question is, are there any that aren't explicitly included that you think should be? So maybe that's one that should be more explicitly included.
Multiple relocations.
Multiple relocations, yeah.
Schools, friends.
Yes, yeah, definitely, yes.
Explain about the low school attendance.
Mm-hmm. So being either unable to like access school because of like your parents can't get you there, you can't get there, or the child is missing school for hate to use the term criminal behavior, but like behavior that is not pro-social, right? And you're kind of missing out on school attendance in order to engage in some of those other behaviors. Yes.
Under the parentification caregiving role for a child,
Mm-hmm.
do you include the child who is stuck into the role of an adult and of a caregiver? Is that under that umbrella?
Yes. Yes. That could be of a parent or guardian figure, or of siblings, right? Where they're really kind of taking on that caregiving role, either of other children or of the adults in their lives. Yeah. Excellent. Other thoughts? Okay, let's go. So what are ACEs? This is hopefully this will play and the volume will play, but this is like a fun little video that kind of explains it very nicely.
Childhood experiences called ACEs are stressful or traumatic experiences that occur in childhood. Abuse, growing up into substance use or mental health problems. When a caring adult or supportive environment doesn't soften those adverse experiences, or when they are ongoing or overwhelming, they can lead to a prolonged activation of our stress response called toxic stress. Think of toxic stress like this. Our bodies were designed to escape predators quickly, and as you're walking through the woods and you see a bear, your brain signals your body to release stress hormones like adrenaline and cortisol. Your heart begins to pound, and your body prepares you to run to fight or run from the bear. It's useful if you're in the forest and there's a bear. The problem is when children face threats to their physical and emotional safety, and the system is activated over and over and over again. What is meant to protect you begins to do the opposite. It becomes damaging to your health, creating long-lasting wear on your body and brain. Children are especially vulnerable to the effects of innocence and toxic stress because their brains and bodies are still developing. The toxic stress releases and other adversities such as poverty, racism, discrimination, and natural disasters, they disrupt the function of vital bodily systems. Simply put, toxic stress can result in long-term mental illness or health conditions. Not only that, the effects that ACEs have passed from parent to child for generations, and the biological changes and behaviors associated with ACEs and toxic stress. A person with an ACEs is twice as likely to suffer from heart disease, cancer, and stroke. 4 times as likely to develop depression, and 12 times as likely to attempt suicide. The good news is that stable relationships and environments and other interventions such as physical and mental health support reduce the risk of ACEs leading to toxic stress and stress-related health conditions. To learn more, visit www.osg.ca.gov.
That's a great little kind of teaser video for more of what we're going to expound on in this presentation. But I like how it really summarizes what to expect as we're talking about the biopsychosocial model. So you may have heard in that video, it's talking about the biological impact of trauma, right? That activation of cortisol, the HPA axis, and the impact that it can have on us physically. So we'll delve into that in a bit. It's a bit of a fun little cliffhanger. But first, we're going to do a pop quiz. We're going to test our knowledge, okay? So our first case, we have Jordan, who is 10. And Jordan is regularly hit with a belt by his father when he makes mistakes. He often has bruises on his extremities, which he tries to hide from others. What category of ACE might this be?
What was the question?
Yeah. What category of ACE, adverse childhood experience, might this be? Physical abuse. Excellent. All right, what about Jaden? Jaden is 6. Dad is in prison. He doesn't fully understand where his dad is, but he feels sad and confused, and the other kids at school tease him when they find out. Which ACE might this be? So maybe, yeah, emotional abuse, maybe. Parental incarceration or separation. Excellent. All right, now we have Isabella. She's 8. She's struggling to adjust after her parents' recent divorce. She now moves between 2 households and often feels caught in the middle of their ongoing conflicts. What might this be getting at? Parental separation or divorce. Fabulous. We've got Malik, who's 7. He rarely receives attention or affection from his caregivers. His emotional needs are ignored. No one checks in on him or how he's feeling or supports him emotionally. Which ACE might this be? Yes. Yep. Excellent. Lena, who's 8, is constantly told by her mother that she's stupid, she's a burden. Mom frequently yells at her and calls her names. And now Lena is withdrawn and anxious. What ACE might she be experiencing? Yep. Verbal abuse or emotional psychological abuse terminology kind of depends on person. Exactly. Emily is 11. She frequently witnesses her father hitting her mother during arguments. She often hides in her room and is scared whenever voices are raised at home. What category of ACE might this be? Yep. Witnessing domestic violence. Excellent. Okay, Sophie's 9. She often goes without meals and has inappropriate clothing for the weather. Her home is dirty. She's responsible for taking care of her younger siblings, and there's little adult supervision. Which ACE might this be? Some parentification. Yep, physical neglect and some parentification. Definitely would agree with that. All right, Carlos is 12. He was repeatedly molested by an older cousin during overnight visits. Was told he would get in trouble if he told anyone. Now he's having nightmares and has a hard time trusting people. What example of ACE might this be? Sexual abuse. Yep. And we've got Tyler, who's 10. Tyler lives with a parent who struggles with alcohol addiction. Some nights his parent is passed out and Tyler has to prepare meals for himself, and he also misses school often. I think I heard something from the back there. What did I hear? Yeah, there's a bunch of them. Yep.
School attendance for one.
School attendance for one.
Investigation.
Mm-hmm.
illegal, maybe.
Criminal activity, parental substance use, yep, excellent. Low school attendance. And then we've got Anna, who's 9. She lives with a mom who has severe depression. Sometimes her mom stays in bed for days and leaves Anna to take care of herself without any supervision or support. Neglect, yeah, more specifically, right, parental mental illness, exposure to that in the home. Excellent. A++. Great job, guys. So ACEs and allostasis, this is kind of a fun term. Allostasis is our body's ability to respond to the environment and provide physiological and behavioral stability. So that means if from that video, right, if we're in the woods and there's a bear and we need to like respond with fight, flight, or freeze, our body can adapt and do that. But then as soon as that bear is gone and we are safe, we can also regulate back down, calm down, be calm and relaxed. Our ability to do that at appropriate times is allostasis. And so when we're under threat, as that video says, our sympathetic nervous system activates. That fight, flight, freeze response that y'all may have heard of kicks in. Some people have a tendency to do one more than the others of those. It kind of varies. And this HPA axis, or the parts of our brain, we've got the hypothalamus, the pituitary, and the adrenal glands, right? Those biological kind of axis, those things get activated. They turn on things like our blood vessels constrict, our heart rate increases, our attention increases, right, to something really specific. Things that we don't need in that moment, like digestion, all slow down. And that's really that fight, flight, or freeze. So if you can think of a time when you've been like really scared, right, you might have noticed you became really like focused on whatever that potential threat you've identified was. Your breathing increases, your heart rate goes up, you kind of feel on edge, you're ready to respond in that moment. That's that sympathetic nervous system activation. It is also associated with the release of cortisol, which is what we call the stress hormone, right? And so cortisol is like coursing through our body. It's getting us ready to do what we need to do. If we need to fight off the bear, if we need to run from the bear, whatever the case may be. All helpful, as the video says, if we are encountering a bear. Generally, when that happens, folks find that their body will then return to baseline after the threat passes. The bear leaves, we've survived the bear, whew, it's time to calm down. We kind of have that adrenaline crash, which you may have also experienced. You know, driving in Tyler, I'm not from here, so, you know, I believe my HPA axis gets activated multiple times while I drive, and then like you have that adrenaline crash because there's so many people who run red lights here, right? I don't know if y'all, but whew. And so, you know, you may have experienced that as well, where you're like on edge and then you're like, okay, everything's fine. Oops. But what happens if we have this buildup of allostatic load is when we are chronically exposed to stressors and our HPA axis is chronically activated and our cortisol is like constantly flooding through our body at really high levels, we have a really hard time turning off that sympathetic nervous system and the HPA axis, even when we're not being encountered with a direct threat, right? So even if we're in a safe place, we're with a safe person, those internal experiences may still be happening. When they are happening, that is a big component that results in those negative outcomes through the direct effects on our health and those epigenetic changes. So this kind of pyramid here shows from like birth to death, the progression of ACEs and allostasis is people who've experienced these adverse childhood events. They have disrupted neurodevelopment as a result of this kind of chronic HPA axis and cortisol activation. The thing we know about cortisol is it is neurotoxic, right? So the more our brain is constantly flooded with it, the more damage it's doing. We experience like social, emotional, and cognitive impairment. Maybe we have a hard time building trusting relationships and asking for help and going to the doctor and taking care of ourselves. We may even adopt health risk behaviors as coping mechanisms like smoking, drinking alcohol, using illicit substances, risky sexual practices, right? All of those things that also have an impact on our health and our functioning, which can lead to the development of disease and disability, and then lead to that early death that we may see, right? As a result of things like perhaps like lung cancer, if we started to smoke quite a bit as a coping mechanism, or something of that nature. Does that kind of make sense? Fabulous. So fast facts. I've got a couple of other videos. We're going to be mindful of the time. If we have a chance to come back and watch these more, we will. Or if not, I can also send you the links and you can distribute to folks as well. Because I think the data is really important, right? Why do we talk about trauma? Why do we talk about ACEs? Lifetime estimates of trauma exposure in the United States is 50 to 89% of people have experienced at least one event that would qualify per the DSM as a trauma. And of those, 30.5% have been exposed to 4 or more traumatic events. That does not mean that 50 to 89% of the population has PTSD, right? Not everyone who has trauma exposure goes on to develop PTSD. But what we know is exposure to trauma is actually pretty prevalent, right? And if we're looking at East Texas in general, and I think these numbers I drew from like 2022, 2023 was the most recent I could find. 15.7 people out of 100,000 in Smith County reported having a PTSD diagnosis, and 54.3 out of 100,000 in Smith County reported being a trauma survivor. Now, what we also know about these numbers is they're probably likely underestimates for several reasons. One is sometimes people are ashamed or embarrassed to talk about trauma that they've experienced, and they don't disclose it. And so then they're never appropriately diagnosed. They don't seek treatment. Some people also just don't know. They don't describe experiences that they've had as being traumas, even if they would qualify, right? They think like, oh, it's just something like bad that happened to me, but only people who are veterans or only people who have been raped can have PTSD, or like those are traumas. But what I experienced, oh, that's not trauma. That's just, I had a rough childhood, or, things have been tough. So sometimes people don't always have a concept of identifying their experiences as traumatic. And that can really be impacted by like health literacy and mental health literacy as well, in terms of what are these experiences. So that's going to impact how we screen when we get to kind of that section of this presentation, being really thoughtful about how we ask questions about these types of events is really important. Yeah. Yes.
Where did the data come from? Slide.
Yes, it came from, I'll have to show you in the references. I don't remember the site off the top of my head. It is a website where you can look at Texas data, and I will have to zoom in and show you. Sorry. It is. I think I sent you also, Lee, a larger version of the references. I can pull them up as well, because I cannot read this off the top of my head. Sorry. But I can show you the reference slide, and I can also send you a larger document. I tried to cram them all into one slide. All right, so from your perspective of people that you've worked with, families that you've worked with, do the Smith County numbers seem like an accurate reflection based on your clinical experience and exposure? Do they seem like under or overestimates? You would agree underestimate? Underestimate?
Yeah, I think that was pretty low.
Obviously, don't know anybody that has experienced some level of trauma.
Yeah. So even just in your own personal experience, it seems like those numbers would be higher. Yeah. I think that's very similar to like my clinical experience as well. Okay. What else might contribute to this? I mentioned a couple of things that kind of could cause that. Is there anything else in talking with the kids or families that you've worked with that you think might contribute to those underestimates? Culture. Mm-hmm. Do you want to say more about that?
You know, I mean, it could be as simple as, one set of parents' perspective on discipline.
Mm-hmm.
You know, corporate punishment, um, this kind of thing.
Yep.
Where in another household, you know, that might not even be an issue.
Mm-hmm. Yep.
I think so much what we see in our area too is generational.
Yeah.
Therefore, it's just accepted as normal. They don't see it as
Yes.
traumatic.
Yeah. There's a generational aspect, like familial norms, kind of as part of that culture. Excellent.
I think to speak to both of those, maybe if Texans are proud people, and I think it just said, no, there's nothing wrong.
Yeah.
Fine.
Yep.
Well, it could be embarrassment, the fear,
Mm-hmm.
but it's also from the family
Yeah.
feeling the same way that they just don't talk about it.
Yeah. That hesitation to air outside of the immediate family any issues or things that may be going on is certainly very prevalent in Texas, and I think especially even in East Texas, right? Yeah. All excellent examples. Great thoughts, everyone. So what are some of these biological impacts of trauma and chronic stress? Like I said, the video does a great job of sort of giving you a brief overview. I'm going to break it down just a little bit more in terms of like biological systems. So if we're looking at like neurologically, what is going on when we're experiencing chronic stress? Our hippocampus, our prefrontal cortex, right? So like the hippocampus is managing some of our like memory, prefrontal cortex. We can consider that the brakes on our brain. So that's what determines how impulsive we are. The amygdala is going to handle some of our emotional response. Those are all really sensitive to chronic stress. So when I said cortisol is neurotoxic, these areas are unfortunately targeted by cortisol and kind of are really impacted by it being constantly just floating around in our brains. So we often see things like decreased volume or size of the hippocampus and the anterior cingulate cortex in folks who have chronic trauma exposure. The amygdala, right, that part that's managing our emotions, and the dorsal anterior cingulate cortex are hyperactive. So we may see more emotionality out of people because the amygdala is like working overtime in these folks. Our prefrontal, the ventral medial prefrontal cortex is hypoactive, which means if we think about underactive, we're not putting the brakes on our behavior as much with that prefrontal cortex, right? So we may see more impulsivity, and that can often kind of be associated with maybe more substance use or risky sexual behaviors or taking other driving unsafely, right? Other things like that that can impact our health and well-being. We also have some like low synaptic density, which means we're losing some synapses in the anterior cingulate cortex and the hippocampus. We also see things like norepinephrine is increased circulating in our brain, but we have like low glutamate and GABA neurotransmission. And then we have neuroinflammation. So I don't know, inflammation in the past couple of years has been a much bigger target of like medical research and understanding. And we see a lot more of that occurring in folks who've been exposed to chronic stress. I think tying in with that in the endocrine system, our hormone system, folks have an overall increased cortisol production. Now, we all have cortisol. We all release cortisol at different times throughout the day. That's part of our circadian rhythm. We don't want to completely get rid of our cortisol. But folks who have this chronic stress exposure, they don't have the variation in the cortisol levels throughout a 24-hour period like a healthy control would have. It is going to be at a pretty high rate constantly throughout a 24-hour period, which is going to lead to disruptions in circadian rhythms. So sleep, right? We might think about like, I'm sure many folks that you've worked with who've experienced chronic stress might have sleep problems, chronic insomnia, or they get their days and nights mixed up. They have a hard time relaxing to fall asleep. Circadian rhythms also determine things like appetites and meals, right? All of that kind of gets thrown out of whack if our cortisol is just through the roof. And there's also been some indications of some increased glucocorticoid resistance kind of in that endocrine system. So we might also think about things that contribute to later development of diabetes or things like that. This is just a nice little image of sort of how some of this is happening. So if we're looking at PTSD specifically, how each of these areas is kind of indicated in keeping fear going and like the re-experiencing portion of trauma as well. The immune system. So again, I've said like inflammation has been big recently. So some recent studies have really shown like chronic inflammation and increased risk of infection are also associated with experiencing chronic stress during that developmental period, which is associated with increased risk actually of later cardiovascular disease. And then we have these epigenetic changes. And epigenetics is the study of like how our environment, the things that we're exposed to, actually impacts which genes are turned off or turned on. So we all have like our genes that we're born with, right? But depending on the environment that we're in, the expression of those genes may be different for different people. So for example, increased maternal depression and anxiety in the third trimester of pregnancy is actually associated with some changes in the genetics of a fetus that can lead to increased cortisol production in response to stressors. So if a mom experiences increased stress and anxiety in the third trimester, can actually lead to some biological changes that make that child more sensitive to experiencing stress and having increased cortisol release as a response to stress, at least for like 6 months post-birth. They haven't done super longitudinal studies on that yet, but interesting finding, right? That these things have an impact. There's some evidence in the literature that childhood abuse can actually impact the expression of 997 different genes in the human genome compared to controls that are not exposed to abuse. Now, genetics are not, right, like that just because one gene is activated doesn't always mean something is going to happen, but we know that childhood abuse can impact up to 997 genes, which is pretty interesting. There's also evidence for things in terms of epigenetics, like research that has shown folks who have ancestors who survived like a significant starvation event or malnutrition. So for example, like people who had a lot of food scarcity in like the Great Depression or something like that, it's associated with like increased weight retention in, you know, their like children, grandchildren, and so on. Because it's turning on genes that say, hey, I need to, like, in order for me to survive what happened, I had to hold on to all my nutrients, and it's turning on those genes in their lineage. So some interesting stuff coming out of the epigenetics world. Specific genes, we're not going to do a pop quiz on this, so you don't have to memorize it. But if you're curious, some specific genes that have been kind of implicated in the research so far are the following. And some of these are things that like transport serotonin. So those would be indicated in perhaps like experiences of depression, right? Or some things of that nature. GABA is also going to be impacting like mood, appetite, things of that nature. Okay, what is a psychological trauma? Things that are going to impact how someone perceives the traumatic event and how they interpret it and respond to it in the moment are going to be things like, did I perceive my life to be in danger? That doesn't mean objectively, like you or I may say, well, but we know for a fact your life wasn't in danger. If you're in that situation and you think like, I am unsafe, I'm going to die, that is enough to have a significant psychological impact on you. If the person dissociated at the time the trauma was happening or immediately afterwards, that's actually associated with some increased distress down the line. Again, the severity of the trauma as perceived by the survivor. Where, you know, from an outside perspective, we can't objectively rate how severe something was. But if the person perceives it as very severe, then it is very severe to them, right? That's the qualification we're going to use. if there's a moral injury component, it can be particularly distressing. So if someone, for example, a common example is in military members, right? If they have killed a civilian in the line of duty, and that really violates like their values, their morals, that would be considered moral injury, right? So if in the course of a traumatic event, we do something that kind of violates our standards, our beliefs, our values, it can result in this concept of like moral injury, which is really characterized by quite a lot of like shame and guilt that can add to the distress. And then if folks really engage in like avoidant coping, so that might be the people that you work with, they start using substances, right? They're avoiding and they're never dealing with it. Pretty unhelpful. Keeps folks stuck. Avoidance can also be just like, I'm never going to talk about it. I'm never going to think about it. But then they come to you 3 years later, you see them and it's like, well, these things keep continuing to pop up, or they pop up in some of these other ways we've talked about, like substance use, impulsivity. They're getting into fights because avoidant coping only works for so long. The flip side of that is ruminative coping. That doesn't tend to be so helpful either. That's the people who are going to be sitting there going over it in their mind, going like, what could I have done differently? If I had just done this, if I had just done that, I should have known that this would happen, and I could have done. And that's also not really helpful, right? Because we're sitting there just chewing on it constantly without coping in a healthy way, without kind of making our cognitive experience more healthy or more accurate. And then coping that is entirely focused on emotions and like controlling the emotional experience also tends to be really unhelpful. So these might be people who really judge themselves for feeling scared or sad or angry, and they're really engaging in a lot of attempts to try to make those emotional experiences stop or go away. Is not always the most helpful. So these are some of the psychological kind of components that can contribute to things being perceived as traumatic and continuing to impact folks as they move through their lives. Questions? These may be things that y'all are familiar with. I just wanted to list from our current DSM-5 TR, what are our current trauma and stressor related disorders? We already talked about not everyone who's been exposed to trauma will meet criteria for one of these disorders, though some will. Particularly if you're working with like children, you may see more of like the first two, that reactive attachment disorder or that disinhibited social engagement, where particularly the children have a really hard time like forming safe and healthy like bonds and relationships with others in their lives, or having appropriate boundaries in relationships. We can see PTSD. The way that the DSM currently breaks it down is there's one set of diagnostic criteria for folks 6 and over, and there's another for folks under 6. And really the difference for the folks under 6, it's all the same like categories in terms of intrusions, hyperarousal, things like that. The number of symptoms that children have to have are fewer, and some of the experiences we wouldn't expect to see in kids. So for example, in adults, one of the criteria is about cognitions, right? Like blaming yourself, others, or the world, or having these really like negative beliefs about others. Kids under 6 may not be able to really have or to express that really like complex cognitive structure. That's okay. What we might be looking for in kids is more increased like irritability or impulsivity, cheerfulness, things like that. So there's just some kind of concession made for where kids are developmentally. Yes. Yes.
So, I mean, a lot of this information, I guess, is just from interviewing and asking people, and the child
Mm-hmm.
around it, what kind of trauma have they had? But is there any kind of a blood test or something that can give you some indicators as far as genes and DNA, and that would help you? Because we have 2 boys right now, and they've been under a lot of stress.
Yeah.
I won't even go into it, but it's a whole lot more than 4 different
Yeah. Yeah.
issues. And and they keep wanting to change their medication. I'm thinking, and they ask us, well, is it okay to change their medication? They ask a whole group of people, including 4 kids. And
Yeah.
I don't know if we should, but some people say, well, they haven't let the medication, we haven't let it, take effect yet. So I'm assuming there's medication that can help with these disorders. And so is there, I'm sure there's medication, but also there is a blood test or some kind of test that also helps you maybe further define some of these things. Is that correct?
So yes, there is medication. We'll talk about it. Actually, in children specifically, psychotherapy is going to be gold standard, even above medication for something like a PTSD. But there are some medications that can be helpful. Unfortunately, we don't have a blood test that helps us diagnose psychological disorders. But if you're looking at how certain medications will be metabolized by the body, there actually is a blood test that folks can do for that. Usually insurance doesn't cover it. It can be a little pricey, but what it will actually kind of do is help the prescriber look at that profile and go, okay, like we should stay away from this medication, or, like this class of medications aren't ultimately going to be super helpful for this person. Let's steer more towards these. So that could be something to look into in terms of guiding treatment. When it comes to psychological disorders, kind of like I said, when we know up to 997 genes can be impacted, unlike something like Huntington's, where it's like if you have the gene, you will develop the disorder. Unfortunately, PTSD is not that way, or depression is not that way. And that's where it gets a little bit tricky when we use a purely medical model to kind of look at and treat things like this. But that's a great question.
I know one of the boys, he's got Williams syndrome, but it is genetic.
Mm-hmm.
So they can determine that and then behaviors from this period of syndrome.
Yes.
But anyway, it would be nice if the people administering the medication would tell us why they want to make that change. Because but looking at this, there's a lot of things that when you have a disorder that you have to look at. And
oh yes.
And there's some big words that I don't even understand.
Yeah.
And so it can get to somebody who's just trying to be an advocate for a child, because this is helpful.
Yeah.
But it's also,
it feels really overwhelming.
Yeah, it's a little overwhelming.
Yeah.
But it's stuff that really is not effective, but it relates to the case we currently have.
Yeah. And you can always ask why. And I always encourage people, families, advocates, whomever, you can always ask why. Like, what is your rationale? Why would we make this change? What are the risks and benefits? Help me understand, walk me through it. What is the evidence? Because you and the children have the right to be involved in care and to have an understanding of what's going on. So I would always say, when in doubt, ask questions. And you can also always get a second opinion. And you can ask if the clinic that they go to does any of that, gene testing. There's a couple of companies that will do it.
I never felt like I have the medication. I'm not a doctor, but everybody on that list, there's 13 people on that list, but nobody's asking the question. I'm thinking maybe 4 kids should ask the question, but I don't see them asking the question. So we're all, well, let's just look at medication. They haven't had let's not change it so soon.
Yeah.
But, maybe I'll start asking questions, and I feel like, well, as a CASA advocate, I don't really have that right to, but they're asking me, what do I think?
Yeah. Yeah.
Tell me why.
Yep. I think if you're being asked, it makes sense to say, help me understand so I can give you an actually informed answer. Because this is just the list of trauma and stress related disorders. My next slide is kind of other diagnostic possibilities, right? So it is a wide range of things that we want to be doing our due diligence to rule out. And that's where things like doing a really comprehensive evaluation can be helpful to sort of determine what's going on. Because again, not everyone who's exposed to trauma will develop PTSD, but we may have kids who end up with things like an intellectual developmental disability, or a depressive disorder, or they go on to develop something like schizophrenia or conduct problems, right? Because they don't meet. And here's the part that's tricky about the DSM, and I say this as a psychologist, right, who kind of has to use the DSM, is it is very one size fits all. And what we know about people is people are not one size fits all. And so, we really have to do our due diligence to understand what specifically is going on with each person that we're working with. I'm big on telling people, and I genuinely believe this, I don't work with people to treat PTSD or depression or schizophrenia. I'm going to work with you to treat poor sleep or, depressed mood or, like whatever they're coming in that's bothering them, because that's what we can do. I don't really care what necessarily we call it. It's what is troubling you and how can we treat that? Understanding this can be really important in terms of helping select an appropriate treatment, whether that's therapy, whether that's medication. We just have to be really careful using it as like the be all end all, because you go to the doctor, you go see your PCP, they do a blood test and they say, hey, your A1C is elevated. And there's a very clear protocol of like, well, at this cutoff, that means I have this diagnosis. That means this is the medication, this is the treatment that they recommend. In psychology and psychiatry, we don't have anything like that. And that's where it really gets much more muddled, right? Kind of fortunately, unfortunately, there's, I think, a pro con there, but that's a great question. So what are the psychological impacts? So we know, and you're kind of alluding to this, those with multiple ACEs are at higher risk for things like taking prescription medications, needing more medical and educational support services throughout the course of their lives, having limitations that are going to impact their daily functioning, receiving special services educationally, occupationally, medically, and also experiencing these kind of diffuse emotional, behavioral, or developmental difficulties. So we see a lot of problems with memory and learning, because remember, the hippocampus is really sensitive to cortisol. So that makes it hard for people, if their hippocampus is impacted, to learn and retain and recall information. We have some problems with attention. Again, if our sympathetic nervous system is activated all the time, we can focus our attention, but we're going to focus it on very specific things, like things we might perceive as a threat, and we're not going to be able to pay attention to anything else that we don't see as that important. And then executive dysfunction. So things like planning, organizing, impulse control. We're going to see some problems with that, right? And so you may be thinking as you listen to these, oh, that could sound like ADHD. That could sound like a learning disability, right? And so for some people, it can also have those impacts where it's going to have an effect academically and behaviorally and in some of these other ways. What are social components of trauma? Sorry. For social support, so we also know the folks who have individuals in their lives who tend to be judgmental or shaming or really send that message of like, don't talk about the trauma, like we don't talk about this, like never speak about it, tends to be unhelpful. Things like environmental risks and exposures. So again, if you're living in that unsafe neighborhood and you have like repeated exposure, that's considered a social component. Access to quality care. Can you get the medication or treatment that you need in a timely fashion? What are some of these familial and cultural beliefs y'all were discussing earlier that impact trauma and trauma treatment? If we believe, well, it's not a big deal and we don't need to tell anyone about it or get help, then things may just keep compounding and getting worse. We know folks who are of a lower socioeconomic status and educational attainment tend to be more at risk. And we also know that having been exposed to one traumatic event makes us at higher risk to experience future traumatic events and adverse life experiences. So that's also something that we would want to think about. Again, some of the social impacts that we can see with trauma are things like those poor boundaries. So you may find in some of the kids or adolescents that you work with, some of them may have like very distant boundaries and it's very hard to be close to them. And others may have very like porous boundaries, and they can't set a healthy kind of boundary with others. They get too close to people too easily. Some folks may isolate or avoid. There's also an increased like likelihood of high school non-completion and unemployment rate associated with a greater likelihood to live below the federal poverty level, which then, as we just saw in the previous slide, can perpetuate exposure to more traumas and like passing that along. Consequences on adult health. I think this is really important because it alluded to this in the video we watched. If you have 4 or more ACEs, you're 2 times as likely to get a chronic disease before the age of 69. And that includes being 4 times as likely to get diabetes type 2, 3 times as likely to have a heart or respiratory disease. People with 6 or more ACEs have a life expectancy 20 years shorter than those who have fewer or no ACEs. That is a very big difference, right? Very, very big difference. You're 10 times as likely to have injected street drugs, 7 times as likely to develop problematic alcohol use, 12 times as likely to attempt suicide. That was referenced in the video. And you're also at higher, you use healthcare services like primary care, emergency department services, and hospitalizations much more frequently than folks who have few or no ACEs, right? So these are some pretty astounding, and this is not all of them. These are just a couple of them summarized, but these are some pretty astounding numbers. So what can we do about it? The first thing is awareness, exactly what y'all are doing, coming, learning about it, saying, okay, what can we do as an individual, as a family, as a community to kind of come together to respond to this? And something that CASA is doing is this concept of trauma-informed care, right? So we want to take a strengths-based approach to interacting with our folks. We want to have that understanding and responsiveness to the impact of trauma rather than ignoring it or writing it off, as it has often been done in decades previously. And we want to create opportunities for survivors to build that sense of control and empowerment. So how can we actively involve them in their treatment, in their care, right, in the process, rather than just doing things to them? And it really moves us through this continuum, I like, from, you know, the historical medical approach was really like, what's wrong with you? Like, what's bringing you in today? And trauma-informed care is going to move us to what happened to you, and then also what's strong with you, right? Not just what happened to you, but also what is actually going well? Like, what are your strengths? How can we build on those? Because everyone's got something that we can use and we can build on. Sorry. Yes.
Because yesterday, Andrew and I were talking about this and about, you know, that we're on our 3rd family in 3 years. And there's been some, the previous family, there, those 2 boys, the oldest boy in particular, had some really destructive behavior and also poor behavior against others, fighting and things like that. We have some issues with the kids now. But, and Andrea said, don't you ever get afraid to be around, or do they ever, you know, I said, never. I've never felt that. But I think it's probably one thing we do as CASA advocates is at number 2, where it's trustworthiness and transparency.
Yes.
They know we're looking out for their best interest.
Yeah.
Their caregivers don't always believe that. We've had problems with caregivers.
Yes.
Kids.
Yeah.
I think that's probably one of the biggest things we can do is advocates to develop that trustworthiness, and then their issues are never manifested towards me that I've ever noticed.
Yeah.
I think that might just building trust.
Yep. And that's a huge component we're going to talk about as part of resilience and trauma-informed care, is that trustworthiness and that like reliability. So one of the things that we want to do at trauma-informed care is build resilience, right? And if we're resilient, that's that ability to adapt to adversity. It doesn't mean that there will be none in life. I wish we could promise that to people, but we can't. Typically, resilience is kind of associated with people who have like, they've had higher cognitive ability, educational attainment, you know, no prior psych diagnoses or psych history in their family. These are protective, the things that are listed here are protective factors against developing PTSD, right? That's kind of like, and you may see some of these you're just born with, and there's not a lot we can do to change. Some of these we do have a little bit more control over. I think, especially if we're looking at things like healthy coping mechanisms and educational attainment. But there are other ways to build resilience that we're going to come back to. One of the first things that we can do is actually just saying, has someone been exposed to trauma? And so we can do screenings, right? This is an example of the ACE-Q for adults, and it literally just walks through like each of the ACEs. Did you feel that you didn't have enough to eat, right? Like, okay, that's neglect. You can just check it, and then you just sum up the total number of ACEs. That gives you that kind of breakdown. This is used for adults. And I listed some adult measures here that we can use for screening. Verbal interview I've included for kids and adults. We want to first consider our context, like how much information is appropriate for us in our role to gather. If you don't need all the details, you don't need all the details, you don't need to ask them. But if your job is to do the screening, is to get the information, then we want to think about how we ask questions. So instead of saying like, have you ever experienced something traumatic, which many people may go, no, we might want to think about asking questions with behavioral descriptors, like, has anyone ever hit you, slapped you, or pushed you? Because then people may say, well, yeah, that's happened to me. But they may not like categorize it as abuse in their head until we ask those specific questions. Or if we're getting to family and kind of cultural practices, what does discipline look like in your house, right? Or, you know, how do you discipline your children? Or how were you disciplined as a child, right? We're going to ask more of those open questions rather than saying like, have you ever been physically abused? Because someone may go, no. But if you ask them like, well, tell me what discipline looked like in your house, they may start to tell you, and this has happened with patients I've worked with, like, you know, their parents beat them with an electrical cord. And it's like, well, that would qualify, but they would not have considered that until, you know, if I had just asked, like, were you ever physically abused? They would have said no. And so we just want to be thoughtful about how we're asking questions. So using open-ended questions when we can, using those behavioral descriptors rather than just labeling things as like abuse or neglect or assault, right, can be really helpful. And taking a non-judgmental approach. I do a lot of work with medical students in my job. I train a lot of medical students. And it's fun because I get to work with them in first year and they're practicing interviewing patients. And there's like all these uncomfortable things we have to ask about, like taking a sexual history or asking about trauma. And they're like, oh, you know, and it's like so nervous to do it. And so a common piece of feedback is like, hey, if the patient can tell that you're nervous to ask about it, they're going to be nervous to talk with you about it, or they're not going to tell you anything. If we can just ask these questions as compassionately and openly and non-judgmentally as we ask any other questions, like the person answering them will also be put more at ease, and they'll be like, oh, okay, I don't have to protect this person, right? I can be more open. I can disclose. And so I want to validate it is uncomfortable. It feels awkward. It feels scary. And it's so important to think about like how we can just do it in a straightforward way. For kids and adolescents, again, I don't know if you are familiar, if any of the kids and families you work with have this data that you have access to, or if you do any intakes here specifically that incorporate any of these. But these are some common like screening measures that we can give to children and to adolescents. Some of them are freely available. Some of them you do have to purchase. But these are some helpful guides for screening for trauma if in any setting that you're in now or in the future, you're interested in doing that. Constructing a trauma timeline. I just included this because sometimes it's also really helpful. As some of you have noted, we work with people who have multiple things that have happened. Getting an idea of like the order in which things have occurred or how many things have happened can sometimes be really helpful, especially if you're looking at treatment options and considerations. When did certain things start? Particularly in kids, ADHD and PTSD get really mixed up. And so if someone isn't diagnosed with ADHD till they're 12, but it happened after like childhood sexual abuse from 4 to 10, I might be more hesitant to say that's actually ADHD. And I might be thinking like, I wonder if it's PTSD that's kind of looking a lot more like ADHD. if we didn't see any symptoms prior to that. So that's kind of where a timeline can come in handy. So how do we build this resilience? One of the most important things, and I'm going to echo what you said, that trust and transparency is the S in our THREADS acronym here, social connectedness. So helping folks build strong, connected, trustworthy, reliable relationships with like safe adults, safe others is really important. How can we show up and be those safe others for folks? How can we activate that thinking and learning brain instead of emotional brain, right? So if folks are coming in and they're always an emotional brain, it's going to be really hard for them to hear and absorb and take in what you're talking about, what you're doing. How can we help them regulate the emotion and get into thinking and learning brain zone? How can we foster and instill hope that things can get better, that they can do better, right? That they can achieve things with their life? Because I feel like a lot of folks with trauma, you have that sense of like doom and kind of foreshortened lifespan and that things are very helpless and hopeless. How can we kind of counteract that? How can we help provide them with skills to regulate or engage in self-control? How can we build their self-efficacy? Again, like, can we offer them choices when and where we can? That can really build self-efficacy. Can we help them kind of feel more empowered to make decisions, to be involved, to be respected, to have a voice? Attachment kind of ties in with that social connectedness as well. An attachment does not have to be to a parental figure, though it can be. And then how can we help them master developmental skills at the appropriate level? One thing you may notice in working with kids and adolescents who've had chronic trauma exposure is their chronological age and their developmental age don't always match up, right? Like you may be working with a 13-year-old who seems much more immature because they kind of have like arrested development. And that damages social connectedness with like peers, right? It makes other things difficult for them. So how can we also foster appropriate developmental skill mastery to kind of get them caught up developmentally to where they are chronologically?
You find that the inverse of that is also true? Because I know we had 10-year-old girls that sometimes they seem like they're 18 years old.
Mm-hmm.
You know, they develop thought patterns and skill sets and coping mechanisms that they should have never had to develop at that age.
Yep. The inverse can certainly be true. And you may also find that it can be very differential, right? So in some domains, they may be like very mature or advanced. And in others, you may find like, oh, they're not. And so it may also be kind of matching depending on like that person's profile, where that developmental level needs to be. I think that's a great observation. We can also do things briefly, like in our interactions with folks. If we're super short on time, but if we have a chance, we'll come back to this and actually do a practice together. If not, I can send Lee some stuff to send to you. But we can do things in our conversations with folks, like using a grounding skill, right? What are 5 things you can see right now? What are 4 things you can hear? What are 3 things you can touch? 2 things you can smell? 1 thing you can taste? Sometimes that can help move people from emotion brain to thinking and learning brain, right? Or let's do some deep breathing together. And I've worked with a lot of people who are like, I've done that and it never works. To which I say, usually they've been doing it incorrectly. So when we do deep breathing, we want to like pretend we have a balloon in our tummy. And when we breathe in, we're actually going to push our tummy out. And when we breathe out, we're going to push our tummy in. Our chest shouldn't be moving. So sometimes if you see people going like this, that's why their deep breathing didn't work. That actually makes you more anxious. So usually I'll try to practice with them that way and they'll be like, oh, that is different. So you can like make it kind of fun and get some buy-in. So we'll come back and practice. But what is evidence-based treatment? Well, the best thing that we want to do is obviously prevent people being exposed to ACEs in the first place, right? There are some good programs out there like Early Head Start. So getting kids like involved in these programs. Adults and Children Together Against Violence, or ACT. That's actually a program targeted at parents and caregivers that teach them like healthy parenting skills and positive parenting skills to reduce exposure to like abuse and neglect in the home during the developmental phase. Safe Care is another program that does a similar thing. The Incredible Years is an intervention that was developed that targets parents, teachers, counselors, like anyone who works with kids and adolescents. They have kind of a program for to like raise awareness, help you recognize what is unhelpful or what could be potentially traumatic, and give you opportunities to kind of like, again, learn safe parenting, safe interaction skills, build those relationships. Other things that we can do for primary prevention are just advocate for policies that promote healthy families, right? Things like access to adequate nutrition and education, and healthcare, and just kind of broadly care for children and families. Because if these things are being done, then it also kind of reduces the risk for those ACEs in the home and in the developmental period. Early intervention is also great. So things like Reach Out and Read is kind of like a mentorship and educational program for kids who have been exposed. There's the Attachment and Biobehavioral Catch-Up Program, and that one is, I believe, out of Kansas. And it is specifically targeted for kids who have had early traumatic exposure, and they're focusing on not just their educational backup, but like catch-up, but attachment and building attachment with safe and healthy figures as well. And this is also where early intervention comes in terms of like training frontline workers to recognize and respond to ACEs and to talk about how to promote safe and supportive environments. And frontline workers is y'all, it's me, it's religious leaders, it's, you know, if we think about law enforcement, we think about firefighters, like we can all kind of improve our knowledge and ability to respond to this. Medically, I want to make sure we got here. For kids and adolescents, the best evidence so far in terms of like trauma treatment and medication more specifically is going to be an antidepressant like an SSRI. So specifically something like a Zoloft or a Prozac would be what we would primarily be looking at. Zoloft has the best evidence in that age group. For adults, we could also be looking at something like a prazosin. This can help with nightmares. If folks are experiencing a lot of nightmares, or like trazodone can sometimes help folks with sleep. Sometimes in kids, we could use a hormone more like melatonin, right? So it's over the counter. We can do that to help with sleep. Sometimes that's indicated. If we're looking at psychosocial treatment, trauma-focused cognitive behavioral therapy, or TFCBT, is going to be our gold standard intervention for kids and adolescents. And what that involves is kids learning relaxation skills, kind of developing their trauma narrative, learning to engage in some cognitive restructuring at the appropriate developmental level, and also learning like healthy boundary setting and communication skills. Ideally, a parent or a guardian is also going to be involved in TFCBT and will also be learning how to support the child in the use of these skills. And the parent or guardian will also be getting some training in some of these skills as well. So that's really our gold standard. We also have some other interventions. I included some for adults as well. So things like EMDR and CPT, or cognitive processing therapy, are typically done for folks like 16 or 18 and up. So kind of older adolescents and adults. But even things like supported education, right? Making sure kids get access to appropriate accommodations in school, or supported employment for adults and case management is evidence-based and is highly effective. Just for the sake of completeness, I've included some complementary and alternative methods as well as some emerging treatments. So the complementary and alternative methods include things like acupuncture, mindfulness meditation, trauma-informed yoga. There's like a little less evidence for the use of some of these with children and adolescents versus adults, but these are some adjuncts to treatment that some folks use, and there's some evidence in the literature to support them. It is a growing field. In terms of like emerging therapies, we have a couple of other medications here, like venlafaxine and risperidone, that are currently under investigation. We have some other intervention types like neurofeedback and reconsolidation therapy that are currently under investigation. And then as you see here, we also have some medication-assisted treatments that folks are currently investigating. So things like ketamine treatment, MDMA-assisted therapy, psilocybin-assisted therapy, things like that. And so to wrap up very quickly, how to implement trauma-informed care in your setting. So first of all, it's shifting our mindset and shifting our organization's mindset from what's wrong with you to that what happened to you and what are your strengths. We can both realize the impact of trauma and the hope for recovery simultaneously and really facilitate and foster that in the folks that we work with. Recognizing signs and symptoms of trauma, right? Some of those things like kids being like their heads are on a swivel, they're irritable, they act fearful, they're very resistant to connection. Like, what are some of those things that are going to tell you, maybe we should think about trauma exposure a little bit more? If you don't already, screen everyone for trauma, whether you think it's there or not, because we can always be surprised. And I think, like we've all said here, it's an underestimate, right? So it's really important that we're screening everybody. Integrate this knowledge of trauma into your organizational and clinical policies and procedures. And then think about things we can do to resist re-traumatization. So think about how the physical space can be re-traumatizing, especially if folks have had bad experiences with healthcare or with mental health care settings. You've got some like great decor and things around, but I'm even thinking of in some clinics, it's just like the sterile white walls and like the sandbag furniture, and it just like it looks very scary. And so being thoughtful about that, being again transparent, being reliable, being trustworthy, giving them a choice. Would you like to sit here or here? Would you like to do this first or that first? And then respecting that choice can really empower folks and help give them buy-in into their treatment. Probably not as relevant for you, but especially like for folks who are doing physical exams, maybe for y'all, consider physical touch and proximity, right? So we don't want to initiate physical touch without asking permission. We want to think about how close we're sitting or standing to someone. If we're approaching them, can we like telegraph that and ask for permission first? And then can we collaborate with kids, families, adults, whomever, as best we can? And then how can we connect them to appropriate treatment and supports as well? That's also part of my goal today is like, if you didn't know TFCBT was a thing, and now we know it's a thing, how can we get kids connected to this service? So I know we're kind of very much at the end of our time, but for questions for you to ponder, we don't have to go over them now. Maybe think about like what trauma-informed procedures CASA and any other organizations that you're already involved with are already doing really well, and in what ways you think you can continue to build on the current practices and go forward from there. I've included a list of resources here. Sorry, this is also kind of small, with some like really great apps and like sample videos and things like that that we can send out if you're interested in watching any of these. Some recommended reading. If you haven't read any of these, I would highly recommend. Bruce Perry does some fantastic work. And so The Boy Who Was Raised as a Dog and Born for Love are like case examples from his career as a psychiatrist, an MD, PhD. The Connected Child is fabulous in terms of like just fostering attachment with kids who have experienced attachment trauma. And then The Body Keeps the Score is a really great exploration of sort of like that biopsychosocial understanding of trauma and its impact. So highly, highly recommend. Thank you all for your time. Like I said, these are my reference lists. I apologize, it's like super small. I did put them into a Word document that is larger, but that's why I was like, I can't read the website where it came from. So thank you so much. Questions, comments, concerns, participation? Yes.
And like for these little folks, I'm gonna say you have to excuse me, I can't remember what category it was. The being flexible
Yes.
wasn't the term. Under there was being male.
Mm-hmm. Resilience. Yep.
Resilience.
Yep.
Be such a good friend.
Yeah.
So men are just inherently more resilient than women.
I have a theory about why that is the case, and I wonder. I don't know if y'all have any theories about why that might be the case. But before I respond to that, I don't know if anyone wants to share a hypothesis.
More resilient.
So in the DSM, one of the protective factors against developing PTSD after exposure to a trauma is male sex. I have a theory that's, I think, decently supported by the literature why that might be, but I wonder if other folks think it's genuinely true or not.
I've always heard that women have more connectors between, in their brain. Men, it's pretty binary. It's either yes or no. With women, they've got all these other things, but we don't have our brains are different as far as connectors, and we don't process it. So maybe that would be my opinion. That's maybe why men might be more resilient, because we don't have the ability to connect all these things and to make us less resilient.
Very possibly.
I think maybe, especially in like today's culture, men don't open up. And if we had a completely open man and a completely open woman, then we could, compare and contrast. But since men are not supposed to feel things, shove it to the side, compartmentalize, push that to the dark corner, never open up again.
Yeah.
But women typically have an easier time to bring things up and explore things.
That's my hypothesis as well. Yeah, is that men just tend to be less open and to ask for help less frequently than women do.
Isn't that more likely to trap them in an endless cycle of, rather than being more resilient?
Yeah.
Seems to me that we need less resilient.
But here's where the tricky part is. If you don't ask for help and you don't get diagnosed, rates are lower, right? And so that's where that's going to be the confound.
But then wouldn't you see more of the other kinds of behaviors, like the fighting, the drinking, the drugs, all of the social behaviors?
Yeah, which do tend to be elevated in men. But again, if you're not disclosing trauma or asking for help, we can't tie it to that. So you just see someone and go, oh, they're just fighting again, or they just have a meth problem, and we're not attributing it to, a potentially underlying cause. Yeah. So this is, like I said, where the data gets tricky. That's a good catch, because I think, again, as you were kind of saying, a lot of this is based on self-report, right? We're asking people their experiences. And some of it's also based on selection bias. It's the people who show up and ask for help, or it's the people who participate in the study and get the screening, right? If you really don't want to talk about it or don't want to ask for help, you're not going to show up to any of those settings, or you might not report accurately when you're asked. That's the fun part about working with people, isn't it?
Very simplistic is that if you don't discuss it, it doesn't exist.
Yep. And that's the perfect definition of avoidant coping right there. Is if I don't discuss it, if I pretend it never happened, then it never happened.
But that was my family.
Mm-hmm. I think it's a lot of people's experience. Yeah.
But it just seems like that would exacerbate the problem if
It does. Yeah.
And then it's kind of thing where that should be included.
Yeah. And again, the limitation is following the data, right? So if the data says a particular gender or sex has lower rates, they have lower rates. We, again, may have our hypotheses, and there may be literature and research, and I think to an extent, as Lee kind of got at, there is that supports this idea that, at least in our society, right, in the United States culture and society, the expectation is generally that men don't ask for help, that certain emotional expressions are more acceptable than others, like anger is more acceptable for men to express than fear or sadness. Or, they may not ask for help. So, it's kind of putting the pieces together. But that's a good catch. Because I would, like I said,
I think there's probably good reason for that. The stigma that gets attached to certain issues, problems.
Yeah.
It could damage a career.
Yep. So if you think about people who are in the military or first responders, very hesitant, right, to ask for help or to disclose these things because they don't want to lose their jobs or get washed out. Yep. And so I think that's, again, we're kind of coming back to those policies and like what we can do to kind of advocate and raise awareness about how this could actually be impacting people, and that there is hope, there is treatment, rather than like there's something wrong with you, so out you go. Is probably not the most helpful because I think it does really drive that stigma, unfortunately. Yeah. Other question. I know it was like a ton of content, and I'm sorry, but I was trying to get I wasn't exactly sure what was the most helpful.
Thank you.
So,
Very
okay. I was gonna say, did it feel helpful and relevant? Okay. Other questions I can answer for y'all?
I think our brains are up 190 miles an hour. Yeah.
The cortisol. You're like, oh no.
Yeah, I have a question.
Yes.
For a kiddo that's a teenager, was in the juvenile detention system for a short time and was put into foster care because of his actions. And if I ask, what do you think of that experience in juvenile detention? And he replies that it's like it never happened. And I just responded that, well, just take the lessons learned and look forward and go forward. And he's very intelligent, productive. And I'm thinking, I don't want to poke if there's no apparent signs of trauma that I see. You know what I'm saying? I want to be open for anything that he wants to talk about, but I'm a little hesitant to poke if it's not going to be productive, if it's going to be counterproductive.
Mm-hmm. Mm-hmm. No, I think that's completely reasonable. I think we also, we don't want to create problems where there are none, in terms of saying like, well, this happened, so something must be wrong with you. Is certainly not the flip of the coin that we want to have. I think part of that trauma-informed care approach, though, is exactly what you're doing, saying like, I'm here if you want to talk, right? Like I'm always here to listen, whatever you want to talk about, whatever like concerns that you have, because it may be down the line that things come up. And we often know, right, behavior is driven by something. Like there's a function to every behavior. So, his previous acting out behavior that got him there, I wonder what was driving that. It sounds like right now he's decided that he wants to move forward, and that's excellent. So I think the more that you can just foster that hope and that empowerment that he is able to do that. And like you said, his stint in juvie is not who he is, I think is very important. Sounds like you're doing great work.
That's what I figured. And he's like a straight A student. He's, going to be taking advanced placement classes. But I'm just aware that being removed from his home
Mm-hmm.
is at some level is trauma there. Mm-hmm. So I'm like, I'm aware. And like, that's what I've said is I'm here whenever you need to talk, feel free to. So, okay. Well, thank you.
Yeah. I think and then being able to consistently be there is so important.